We're here today to remember the Sydney Marie Snyder story. She was a patient here, a 7-year-old child that had ALL. In September of 2007, she came to Children's National to be treated with an experimental drug. Her treatment was the last options for her. Before coming to us, she had multiple relapses and all treatments, including a BMT, a bone marrow transplant, had failed. While she was with us on an experimental protocol, a med dose error occurred, a medication dosing error. As a direct result of this error, she was taken off that experimental protocol. She subsequently died of her illness, leaving a grieving family and a distraught team here at Children's. This was 9 years ago that this happened. We acknowledge the fact that we failed Sydney as an organization, her parents, her family, her friends. When they come to us, when parents and children come to us, they expect we do things right. Yet we acknowledge that despite our best intentions, we, of course, sometimes will make mistakes. And high reliability is that drive to decrease these mistakes. And the discussions that ensued with risk and the medical officers, the family following Sydney's death gave us a significant part of their settlement. And these are a humble family, a firefighter and a school teacher. And they gave a substantial portion of that back to the hospital to say, we don't want this to happen to a child again. And from that, we have the Sydney Marie Snyder Endowed Lectureship. We take this lectureship very seriously as it gives us a pivotal point every year to reflect on medical errors and the harm they cause children, but also to look forward and see what the future brings. It's really with great pleasure that we introduce Richard Brilli, the Chief Medical Officer of Nationwide Children's. Today he's going to talk to us about looking forward, leadership, and what he calls safety too. Rich has an incredible CV and academic pedigree. He has friends from this room, and I welcome Dr. Holbrook, a longtime friend of Dr. Brilli's as well. He did his training, internship, and residency at Cincinnati, continued on fellowship at Cincinnati, went to Cooper Hospital in New Jersey, then back to Cincinnati, maybe a lot of roads lead to Cincinnati, then at Nationwide Children's, where he's really set the national landscape for pediatric safety and quality. He's going to talk a little bit about some of their initiatives, but he was really one of the first individuals to say, shine a light on these errors. You might not be catching enough. Make your denominator bigger, and that's how you're going to have real improvement. He's not done that once or twice. He's made his career of that in the last decade. We are very fortunate to have Rich today. Thank you. And Rich challenged me, and this is the next slide, challenged me before coming here. He said, you know, sometimes my talks will be, I don't know what word you said, Rich, perhaps exciting, provocative, you know, no, not boring, but, you know, is the organization right for that change? And I want to take you back to this, because I did not seize this opportunity back in January, and I'm going to seize it again. We asked you all in January, do you think Children's National can become a highly reliable organization? We talked about what an HRO is, and we had 77 audience clickers. And what dawned upon me, and David, Kathy as well, is everybody said, yes, we can. So that's amazing that people have the willpower to take us to the next level. So Rich is going to start us a little bit on that journey that we've been moving along. Give us just a second while we transition. No. The last one. Maybe it's good to start with the end, Rich.
Yeah, let's go with the last slide.
Where we're headed.
There we go.
There we go.
Good morning, everybody. It's a great honor to be here to address such an august group. And we're going to spend the next 45 minutes, and I'm going to teach you everything you need to know about quality improvement in 45 minutes. If you believe that one, I've got a waterfront property in the Everglades to sell you. I see Alan there, and I just want to start. I did 2 months of my critical care fellowship in the 80s here. I did it mostly in Cincinnati, but came here. It was the premier critical care fellowship in the country at the time. It still may be, but for sure it was then. And I had one of the worst nights of my medical career working in that ICU, 2 or 3 codes at exactly the same time. The fellows covered the emergency room as well, so there was a code down there. And it was not a tradition to call in the critical care faculty, and I think I was honored to call in Dr. Fields and come help me run some of those codes. It was a very stressful night. But in the next morning, I said, if I can get through this night, I can get through anything. So I have warm memories of that, and it was indelibly imprinted on me, Alan, so thank you. We're going to talk about a shared vision, and we're going to talk about a lot of different things. You know, you can do seminars on quality improvement. So this is going to be a potpourri of things that I think are important for organizations to think as they try to drive change. So the British Medical Journal in 2000 said, talked about, are we ready for safety? And in 2000, if you're doing QI, you're a bit of an oddball outlier. Brian and I started doing this stuff, and we were a little bit odd in thinking about this. Now in 2015, if you're not doing QI, you're an oddball outlier. It's mainstream. Talking about zero harm is mainstream. When we started talking about zero harm 10 years ago, people thought you had 3 heads. So this work that we're doing nationally has finally come full circle, and it's the kind of thing that we all need to be doing. So I'm going to talk about 4 things. I'm going to talk about how leaders drive change, talk about organizational culture, and show you some results from our place around when you have an improved organizational culture that actually is related to harm reduction. And then the last part of the talk about what might be next, because I think many of the things you're doing and we're doing and the other 115 hospitals and the solutions for patient safety, we're all kind of doing the same thing. But I have some other ideas that I think where we need to be thinking, what's next? Because nobody's gotten to zero yet. We've all made a lot of improvement, but nobody has eliminated harm in their organizations. So what are the new things that we need to think about that can get us there? So you have a famous person working here. Dr. Shah was one of the first to publish around dramatic reduction in serious safety events in the Journal of Healthcare Management, along with Mary Ann Hilliard as the first author. So, I mean, this work has been going on here for a while, and so much of what I may tell you, you'll say, yeah, I heard that a million times. So maybe I'll just reinforce it. We published a year later a little bit more comprehensive overview, not only around serious safety reduction, but also harm reduction, cost, ROI on safety work, and also mortality reduction. And I'll show you some slides about that in a second. But I want to give Rahul kudos for leading this effort here and being ahead of his time in terms of thinking about this work. Now, zero, the elimination of harm, is commonplace. These are just a few of the logos of children's hospitals around the country that are focused on eliminating preventable harm. But, when we started talking about that, people said, you can't eliminate preventable harm. It's impossible. Well, nobody's achieved it yet, but it's the right goal, because if it's your niece or your nephew or your son or your grandchild, if they get harmed, it's unacceptable. And so the concept of getting to zero is the right concept, even though we all have to struggle to try to get there. And you can see you're zeroing on zero there as well, but from around the country, Stanford in Colorado and Cohen in New York. So leaders need to know where they're going. And I think many times that seems self-evident, but as I see leaders, younger leaders around my organization, sometimes they want to be leaders, but they don't know how to get there and they don't know how to get to the goals that they're looking for. So not only do you have to know where you're going, but you have to know how to get there. So in my view, there are 4 big concepts around leaders who are driving change. You need to sell an organized vision. You need to inspire and manage teams, and I think that's one of the most important things. People underestimate the importance of having a good team and figuring out how to inspire that team. You need to have a method to achieve results, and you need to celebrate success. So let's start with the organized vision. So at Nationwide, we had a significant burning platform in 2009 when we started focusing on safety and harm elimination, where real action was necessary. And what do I mean by that? Well, in 2009, we had nearly 500 children seriously harmed. Our board had never heard that number before. They'd seen rates and control charts and run charts, 0.01 medication error per 1,000 doses administered, or 1 central line infection per 100 line days, 1,000 line days. But they'd never seen this number before. We had 1 serious safety event every 11 days. Over the past 7 or 8 years, it's now once a quarter. So it's not zero, but it's dramatically improved. But all of these kinds of things you have in your organization, we have them in ours. But when you add them up and talk about how many kids, that inspires everybody from the board to all of the staff who work here to say, we don't want to harm any kids when they come to work here. And I know you've heard that message before, but it's an important message that needs to be emphasized. 1.4 kids per day in 2009, 1.4 kids seriously harmed. We have a Sydney story as well. Her name is Emily. She came into our hospital with hemolytic uremic syndrome, and as part of her care, she was getting intermittent dialysis. We gave her potassium in her IV fluids. we also gave her blood, which has a lot of potassium in it, and her potassium went from 3.5 to nearly 8. She suffered a cardiac arrest. At 4 years old, she died in our organization. I tell this story regularly to remind everybody this is real. This is not some bunch of charts that I throw up there. We kill kids in our organization. And I use that word on purpose as well. It's a charged word, but you have to be able to talk about that, because if you don't, then people can just, oh, I'll go back to my job and I don't have to think about the harm that we cause. And I think that it's important that you learn how to say these words as well. And of course, Rahul just talked about Sydney. I would say that every hospital in the country has had an Emily or a Sydney in the past or in the future. And this work that we're doing together nationally and you're doing locally is all about preventing Emilys and Sydneys in all the other organizations that are focused on harm elimination. So, a clear and understandable vision. You know, I think what we ought to do is work on eliminating harm in our hospital, because it's the right thing to do. As opposed to, we seriously harm several hundred kids a year, and it's important that we eliminate that in our organization. You have to deliver the message with passion and zeal, otherwise it's just another thing that we're working on. And so it's important as a leader that you figure out how to say that. I talk on our quality improvement course, and some of the folks who are here from that, you have to have passion and energy for this stuff. And if you're going to come across as, oh, it's just another thing we do, you're not going to get the same results from people working and focusing on this, as opposed to making it the thing that we do. That's why we want to get outcomes for heart surgery in our critical care units and our nephrology group and all the other things that we do here. If we hurt kids, we eliminate, you know, all of the great work that we do. So focusing on this is essential. The other thing is that people buy into the individual. People need to know who you are, and they need to understand your passion and zeal as you make this case. I'm an ex-military guy, and Colin Powell, you know, said that great leaders are almost always great simplifiers who can cut through the debate, who can make the case, who can make people understand why this is the right thing to do. So every person in this room is a leader. I don't know how many residents are here, but usually the residents sit in one spot, and maybe you're back over there. You are leaders in this organization. When you do things on the unit, the other staff watch what you do. When you roll your eyes about, you know, we don't really have to follow that policy because it really, it's Shaw's policy or Brilli's policy. The nurses and the respiratory therapists see you do that. You're a leader. The shadow of your work, people see. The nurses are leaders. Everybody, you know, has a leadership role. So, you know, when you have a body language that doesn't buy into the work you're doing here, people notice that. So the shadow of a leader is important, and how you talk about these kinds of things is really, really important. Branding. You have zero in on zero. We have zero hero. It's our zero's the goal. It's a heroic effort to get there. It's kind of how we got to that, and we train all 10,000 people like you do here. But the message needs to be simple, and you know that's a simple message that people can understand. Almost everything we do around quality improvement falls under this zero hero umbrella, even though it's not just safety kind of stuff. So simplicity of message, I think, makes a big difference. We talked about the Preventable Harm Index at Nationwide Children's. We published in that in 2010. It's the number of kids. It's not a rate. It's not a control chart. It's not all of the other charts that we're used to seeing. It's how many kids, and you can read the various harm events there as well. It's about how many kids. People, in my view, get inspired by how many kids. Don't get inspired by some of the run charts I'm going to show you a little bit later. Organizational framework. So not only do you have to have a vision, but you have to have an organizational framework. Every QI meeting I go to, somebody shows these Institute of Medicine domains of transformational outcomes. So far be it from me to criticize the Institute of Medicine, but I'm going to criticize the Institute of Medicine. I think these are sterile, non-motivational, non-inspirational words. They cover the domains of quality, but our staff, and I am not inspired by these words, and in fact, as soon as I leave this slide, I can't even remember what they are. So we've taken a different approach. We have a family-centered quality and safety strategic plan. Do not harm me, cure me, treat me with respect, navigate my care, get people through our system with efficiently and effectiveness, and then keep us well, which is our population health domain. We've been using this now for 6 or 7 years, and lo and behold, they actually line up exactly with the Institute of Medicine transformational outcomes. So at least in our organization, and I give this slide every time I give this talk because I'd love for everybody to think more from a quality family-centered strategic thinking as opposed to these words. I've never given a talk at the IOM, but if I do, I'd show this slide there and they'd probably boo me. But the bottom line is I think there's real opportunity to focus on what people care about, the patients that we care about, and the families that we take care of, not these more succinct but sterile words. And we published this in Pediatrics year before last. And all of our projects, all 100 of them are all not intended for you to read this, but all of them are lined up under these domains. There's really nothing in quality and safety that doesn't line up underneath these domains. You know, we have 100 active projects in these domains, and we have 50 maintenance of certification projects for the attendings in the room who need their Part 4 maintenance of certification all lined up under these as well. You really don't get to do a quality improvement project unless it lines up under one of these domains. Okay, teams. I am a firm believer at our place, our medical directors of patient safety are a physician and a nurse. Almost all of our teams are co-led by 2 different disciplines, physician respiratory therapist, nurse respiratory therapist, physician and nurse is our primary leadership group. It has to be multidisciplinary, and we have parents on many of our teams, not all of them. You know, in terms of forming an effective team, you may need to recruit talent, and it's your job as a leader. Everybody in this room is a leader. It's your job to know who the talent is and to bring people into the fold to be on these teams. You know, some people are not meant to be on these teams, and you can coach them and you can try to do that, but some of them just aren't able to get on board with how to be a member of a team. And it's important for you as a leader to help coach them, but sometimes removing them from the team is the best approach if you're going to try to get results. And I think the most important member of a team is the naysayer, the curmudgeon. You know, you need to have somebody who's going to tell you, you know, Brilli, I don't really think that's a good idea. And then hopefully say why, because if they don't say why, then I'm going to say, okay, tell me why you think that. But it's important to have that person close to you, you know, friends close, enemies closer. But the bottom line, the naysayer is not an enemy. It's just somebody who's not going to be a yes person. And if everybody on your team says, oh, yeah, Brilli, great idea, Shah, great idea, you know, you're not going to get the richness of debate and conversation. So it's an important member of the team. Again, military guy that I am, you know, Dwight Eisenhower said leadership is getting others to do what you want them to do because they want to do it. Think about that for a second. You want them to think it's their idea. You want them to think that this is important work, and it didn't come from you, it came from them. There's an art to that. Sometimes it's a conversation with the individual. Sometimes it's how you set the framework of the outcome that you're trying to get. But it's really, really important to have people line up behind you, but also feel like they're actually dragging you as opposed to you dragging them. And so as you think about forming teams, that's an important piece of things. If your door is closed every morning and people can't come to you, they're not going to come to you. If the first thing that you say to them after they bring up their idea is, okay, I'll think about it, they're going to stop bringing things to you. Colin Powell again says, as soon as the soldiers stop bringing you their ideas, you know, you stop leading. So it's an essential mindset that you have to have, even if you're somebody like me who thinks I always know the right answer and I always know where we should go, which of course isn't true, but I do think that sometimes, I'm being honest. You have to shut up and listen. And sometimes what I try to practice in meetings is I try to be the last one to say anything. Even though I start the meeting thinking, why do we need this meeting? I know how to do this, and we just go ahead forward. So I try to practice being quiet and let everyone feel comfortable speaking up. And for most of you in this room, especially some of the senior folks, you're used to being in charge and you're used to maybe, you know, directing these meetings. I would give you advice to try to be quiet and not talk until the very end. And maybe what you say is, okay, here's what I heard, and here's how I think we should move forward, as opposed to here's what we're going to do. And the other thing is, as soon as you open your mouth as a leader, my boss tells me this about me, as soon as you open your mouth as a leader and start talking, thinking stops in the committee room. They say, okay, well, that's what Brilli thinks. Why do I need to offer any further advice? So as best you can, stay quiet, listen, learn from what's going on, and then try to bring some of it all together. Anybody in this room had any of your ideas stolen by somebody you worked for? Nobody? Maybe you're not willing to admit it. All right, I have. It's demoralizing. Demoralizing. One of the most important things for you to think about as a leader is give credit to the team. Here I'm here privileged to talk about Nationwide Children's work as we move forward, but it's not me. It's the 10,000 people who have bought into the work that we've accomplished. And so, as Harry Truman said, it's amazing what you can accomplish if you don't care who gets credit. I used to have that sign on my door, but now we have a glass door, and they won't let me put the sign on the door anymore. But it's really, really important to stay mindful of that, because it's sometimes easy to say, well, I did all this, I did all this. The people who actually did it are very demoralized when you steal that from them. So be mindful of giving credit and being humble about what the team has done. You'll get your due credit as things move forward and you get outcomes. It's not about I, it's about we. We, not about me. Google did a study on safe teams. They call it the culture of psychological safety. And what they found is that a good team, people feel that they will not get embarrassed as a member, that they can speak up and they won't be embarrassed, that they will feel as though that people will listen to what they have to say and they can feel safe speaking up. Not all meetings go that way, and I'm sure you've been in meetings where maybe one or two people dominated the conversation and not everybody got to talk, and part of the reason may have been that they didn't feel being willing to speak up about that, and so I thought this was important. This just came out last year from Google. All right, all kumbaya is good, but all kumbaya includes holding people accountable. You have to be willing to set goals, set aims, hold people accountable for that, expect them to achieve it, but when they don't, work to try to put in place other systems that will get you the results you need to. It's hard for leaders to have that crucial conversation. I see a lot of leaders in this front row, and I know you've had those kind of conversations, but it's not pleasant to say, we're not getting the results we need to. How can we get there? And I'm not going to tell you how to have, there's books written on that, but the bottom line is, if you don't hold people accountable, yourself included, you're not going to get the results that you want or at the pace that you want. All right, when you drive change, I don't believe the data. It must be wrong. That's the first excuse I hear, especially from physicians, including me. I've said that before. I try not to say it anymore. We're too busy. You're busy all the time. Our place, we're on redirect for the ICU right now, so we're really busy in our place literally today. So people don't have time for this stuff. Well, this actually isn't extra work. It is the work. What we do around quality improvement and driving change is the work. It's not extra work. And I think you have to begin to get that message out to folks. And this is, we're already doing that. Well, maybe you're doing it 20% of the time, but to get the results you're looking for, you need to be doing it 90% of the time. So measuring compliance with whatever project you're working on is really, really important. This is the #1 thing that people use. So evidence-based medicine, I hear it all the time, over and over and over and over again. Where we have evidence, let's use it. But in pediatrics, we have so little evidence for almost anything we do. There's no evidence for how we manage the ventilator in pediatrics. There's no evidence for how we manage the blood pressure medicines in pediatrics. We just do it. I learned it from Alan and Peter, and I teach my fellows. The bottom line is, hiding behind there's no evidence means we'll never get anywhere. So where there's evidence, use it. But most of the time in pediatrics, there isn't pediatric-specific evidence. So we can't be paralyzed by that. We have to figure out how to move forward without the evidence. I would say that in the solutions for patient safety work in your hospital and our hospital, we're creating the evidence. We're figuring out how to do this stuff in pediatrics. You got to publish it, though. It doesn't become evidence in an abstract. It becomes evidence in manuscripts. So those of you that have academic careers here, you need to publish this stuff. The job is not done by going to a national meeting and presenting an abstract. In fact, that's actually not even the job. The job is to take that abstract and publish it and putting it in peer-reviewed journals so others can see it. People don't see the abstracts. They do see the papers. Okay, how do we get there? So our model is the model for improvement. I know that you do some lean thinking, lean work as well. The folks who are coming to our quality improvement course are learning about the model for improvement if they didn't already know it. But the bottom line is you need to have a critical mass of trained leaders. You need to have a common language. When you use Gemba walks, and the IHI model for improvement, there's different language there, so people can get confused. So I think it's important that we think about having a common language and approach. This is a sampling of our quality improvement course. This is the CEO who comes to our course, Dr. Allen, Dr. Newman. I'm glad you're here, sir. So we have a lot of senior leaders there, and we have trained about 200 students, not just physicians, nurses, administrators, respiratory therapists. We currently are honored to have our colleagues from Children's National at our course, and we have some folks from Ochsner Children's Hospital in New Orleans as well. This is our last group picture, and this is some folks who I see in the front row here who completed the course last time. We're really honored to have have you here. It is a great cross-fertilization. We learn as much from you all coming as hopefully you learn from us, because we see some of the challenges you have, and we hopefully have common challenges that we can work on together. So keep coming. We really enjoy it, and we're honored to work with you. So what about this course? Is there an ROI in this course? We've been studying this, and we're getting ready to publish this in the next couple of months. We started looking at all of the courses before the course and after the course. And what I want you to see here, 4 domains. We validated a survey from the ACGME. They gave us permission to use it. We're on QI knowledge, using teams, managing data, and sustaining and spreading. And that's our competency types. And we had a 0 to 9 scale from novice to expert. And you can see a dramatic difference in the before, the blue bars, and the after, the blue bars. I'm sorry, before blue and then after black. 106% increase in competency. So there's several papers published on that already around people taking quality improvement courses, that people get smarter. But one of the things that we also started looking at, which is, in my opinion, the real ROI, is that we actually measured productivity of the people who have taken the course, productivity in the scholarly and work. And so we have dramatic improvement in presentations outside nationwide for the graduates of this course. We have a significant improvement in publications for the graduates of this course. I'll show you some of that data in a second. They're out teaching QI not only intra-institutionally, but actually in other places. They're also leading QI projects as part 4 of their maintenance certification. To me, this is a real ROI in terms of scholarly and academic productivity that comes from people who have taken this course. So shifting from that ROI to driving system change, 2 big domains: changing system culture, having project teams. So I could spend an hour on this slide. I'm going to spend a minute. It starts in terms of driving change in the C-suite. If Dr. Newman isn't into this, you're not going anywhere. And the board, they need to be into this work. But they don't do the work. They just need to make sure that keep the relentless pressure. How are we doing? How are we doing? What's going on? What's going on? The board quality committee needs to be asking those hard questions. And I was just talking to some folks before the meeting. You know, you've got to train people in high reliability. I'm not going to talk about that in detail. You've got to train people on how to reinforce high reliability thinking and methods. You've got to have an in-depth root cause analysis process with a fair and just accountability, where you balance punitive culture with a culture where laissez-faire, I can do whatever I want and nobody holds me accountable. You've got to have tactical work teams, and you've got to have internal and external transparency. Our serious safety event rate is on our internet for all to see. You can go to our website and see our serious safety event rate. I know you have a little bit different malpractice climate here in Washington, D.C. than we have in Columbus, you know, the nice Midwest, but I would sure love to see serious safety event rates of all the children's hospitals on their internet, so I could go and see who's the best. And I can call up their chief quality officer and say, how do I learn from you? What are you doing that we're not doing? So what does all that cost? There was 50,000 hours in training hours. We have ongoing monthly training, which I understand you do it every 2 weeks. We do ours in 2 hours. You do it in 4, but so maybe we have cut things out that we shouldn't. Our QI infrastructure has gone from 6 people in 2007 to nearly 40 in 2015. A lot of people. Every single one of them are working their behinds off, and those of you that have taken our course, you can see how hard they work. We have 13 industrial engineers focused on in every service line, not one per service line. One industrial engineer may be covering 2 or 3 service lines. These are really smart, non-clinical people. Highly recommend bringing engineers into this work who understand quality improvement. They don't have to, I have people who can talk about hypoplastic left heart syndrome who are industrial engineers and don't know anything about the clinical care, but they are so smart. They pick up what they need to know, and it's really an important investment. So we started with a budget of $500 in 2007, and it's $3.5 million a year. So I'm not telling you this is cheap, and I'm not telling you it's free. I'm telling you you're going to get the results that you want, but if you try to do it on the cheap, you may get there, but it'll take a lot longer. You need to have teams, and you need to have a standard method. I'll just spend a second on this. So the improvement model is what are we trying to accomplish by when? We will decrease central line associated bloodstream infections from X to Y by June of 2017 and sustain it for 6 months. That's a smart aim. You know whether you get there or not. You have to write it down ahead of time. Now, how will you know that change is improvement? That's that run and control chart stuff that we're all used to seeing. How do you know what are the things that you need to do to get there? Well, that's what an aim and key driver diagram is about. I don't have any aim and key driver diagrams in this talk to bore you with, but you need to understand how to do that. So it's the roadmap. Every meeting you go to, you have this aim and key driver diagram. We're working on these 6 interventions. These next 6 are future interventions, and these other 6 we've completed already. And then PDSA, small tests of change, to test your hypotheses about how to get where you need to go. So culture. High reliability is what some people talk about, but I think there's more to it than just high reliability. It has to do with how we treat each other. Our people, there's a mutual respect going on. So another slide that I could spend an hour on, or maybe even a half a day on, you know, Wyke and Sutcliffe have been talking about high reliability systems for a while. They have 3 books on the topic. But I think key concept is preoccupation with failure, which is we find and fix the things that are going wrong. I'm going to suggest towards the end that Safety 2 doesn't talk about preoccupation with failure, it talks about preoccupation with success, and I'll talk to you about how we're focusing on that, or starting to focus on that. You're going to fail and you're going to have harm events. You need to have a commitment to resilience. I think those are the 2 most important principles that Wyke and Sutcliffe have talked about. All right, so we've been tracking our safety attitudes questionnaire since we began this work in 2008 and 2009. The black bars are safety climate, the gray bars are teamwork climate. We've had a statistically significant increase in our safety and teamwork climate over the past 6 years. We published this work in the Journal of Patient Safety just in January. But there's a clinical ROI on this stuff. So you saw that green arrow is going up, so we're improving there. So the black line is improvement in our safety attitudes questionnaire, and you can see the times. The red line is our preventable harm index. There's not a statistically, I'm not saying there's cause and effect, but they're both going in the right direction. We think there's a clear association. This is for the whole organization. For the ICU, there is a statistical association. So the open circles are serious harm reduction in the pediatric ICU. This is from 2010 to 2013. And the triangle and squares are improvement in safety and teamwork climate. Statistically significant association between improvement in safety and teamwork climate in our pediatric ICU and harm reduction. So this stuff works. If you have a culture that's improving and you're focused on mutual accountability and working together, it's associated with harm reduction. So I think this is an important piece of what we do. So we have actually discovered the Holy Grail in terms of how to do this culture stuff. And I just want to tell you what that Holy Grail is.
When we asked Reebok to send us Terry Tate, some people thought we were crazy. But I'm a firm believer in paradigm breaking, outside the box thinking.
Hey, buddy.
Break was over 15 minutes ago, Mitch!
And since Terry's been with us, our productivity has gone up 46%. We're getting more from our employees than ever before.
You know you need a cover sheet on your TPS reports, Richard. That ain't new, baby.
Hey, Terry.
Hey, Janice.
But what's really impressed me is how Terry's become part of the Felcher family.
Yeah, baby.
He fits right in here.
That's a loan business call, Doug.
To be honest, I wish Reebok sent us 10 Terry Tates.
Well, that's the ultimate in punitive culture, which, of course, I throw in here to make you laugh a little bit. But the bottom line is there is a balance in holding people accountable. This is the ultimate accountability. You know, if you get tackled by Terry Tate, you're probably not going to do it again. Of course, you may be in the hospital for 6 months on the surgical service. But, again, it's an important way that people need to be held accountable. So, in my view, you have to have improved culture, safety and teamwork climate. You have to have project teams using a standardized methodology. Both are necessary, and either one alone is insufficient. Success. Keeping good things in front of people motivates and inspires them. Nothing succeeds like success, said almost 200 years ago. So if you've got charts that look like this with green arrows, keep them in front of people. They deserve to see them. They need to be on your intranet where people can see. Put them on your internet if you want. We've done that in our place. But you need to have people feeling as though this hard work I'm doing is getting results. You know, we've been honored to win a couple of awards, the IHI, the CHA Safety Award, and the McKesson Citation of Merit for Hospital Association Quality and Safety. So we keep that in front of people. Dramatic improvement in quality improvement publications over the past couple of years. And we feel like this is a responsibility. It's external validation of what we're doing, but it also gets the word out. As I said earlier, an abstract is nice. You got to put it in a published literature, whether it be nursing literature or other medical literature. And this has been a real demonstration of external validation of what we're doing. We have a quality improvement fellowship that we're starting in July. Our first fellow starts in July. So I think, again, a way to train the future Rahuls of the world in terms of running quality and safety programs. So I'm going to shamelessly plug this, and there's handouts in the back. We're starting this next quarter the first journal ever in the world on dedicated to pediatric quality and safety, the first one. It's going to be an online journal, but it's dedicated to just pediatric quality and safety. So send us your papers, a new journal getting started. You know, we need for you to send things, but I think it's a way for us to put all of that stuff in one place, and you don't look at the 2 articles in pediatrics and the 2 articles in the Journal of Pediatrics and the 2 articles in all of the other journals that are out there, the 1 or 2 in pediatric critical care medicine. So, and you'll see some of your colleagues on this list and on the handout. Brian is an associate editor, David Stockwell is an associate editor, Rahul's on the editorial board. So we have a number of people from your organization who are going to be participating in this work. Sorry, shameless advertisement, but so some results. So this is your serious safety event rate. Rahul was willing to send this to me. You've had a 66% decrease. Congratulations, that's great work. It's not 0. Ours isn't 0 either, but it's a dramatic improvement. We've had about an 85% decrease. I looked it up this morning on our internet, our 198 days since our last serious safety event. So again, improvement. And you know, there's this kind of plateau here. And one of the things is we've got a new plateau, which is a good thing. It's even lower. It's the lowest we've ever been. So we feel like some of this work is really translating into a new sustained plateau at the lowest level we've been on our serious safety event rate. This is your harm index. Rahul, again, was willing to share that with me. I want to just highlight this number here. You got a ways to go. I'm going to show you ours. We got a ways to go as well. But again, keep drumming on the fact that this is how many kids that are being harmed. So this is in a bar chart in our work, and it got worse before it got better as our detection improved, and we've had about a 55% decrease. But this orange thing was bothering me. Why is that? It looks flat. We're not improving anymore. And you want to have people see nice green arrows if you can, because they get inspired by seeing arrows that are going down, or at least you need to be able to explain why it's not going down. So I started thinking about why, and I was showing this to Rahul before. So what we actually have found, we talk about how many. But on our organization, we've had a 40% increase in patient days since 2009. So we've had a 40% greater opportunity to cause more harm. And so actually, these last 3 dots here are statistically significantly better outcomes in terms of our harm numbers, but it's normalized to the number of patients in the denominator. So I now have at our organization a dual message. 0 harm, 0 harm, 0 harm we have to eliminate. But we are improving, and even though those last 3 bars look flat, they're actually not flat. And when you normalize them, they are statistically significantly lower than the past. So if you had a dramatic increase in your patient days, you might want to normalize this and see 40% is a lot. But don't lose the message. As soon as you start talking about rate again, this is a rate, it's not numbers. As soon as you start talking about rate again, people are going to, oh, I want to see the rate all the time. And they forget that that's actually, in our case, 250 kids, and in your case, 178 kids. So we have a ways to go, like you do, to get to harm elimination. Sort of the last data point, this is our overall mortality. The blue bars represent before we started our quality improvement. The salmon bars represent after our quality improvement. We've had a statistically significant 25% decrease in overall all-comers hospital mortality. We published that in the Journal of Pediatrics a couple of years ago. This is updated through 2014. That's 260 kids who didn't die in our hospital. That's the ultimate big dot outcome for all of this quality improvement work. You can talk about ROIs and harm reduction, but if you kill fewer kids, I use that charged word again on purpose, you know, you get that's the ultimate outcomes that we're looking for. So, what might be next? You've seen that we're not at 0, you're not at 0, Cincinnati's not at 0, CHOP's not at 0, take your pick, nobody's at 0. So we still have work to do. So I propose a couple of things that we might want to work on together. So safety 2 is one, and diagnostic errors is another. In fact, diagnostic errors are not in our harm index yet. We're going to have to start to figure out how do we capture those and put those in our harm index. So let's start with safety 2. How do we get to 0? Can safety 2 get us there? So if you look at events in a bell-shaped curve, you know, sort of to the left is bad and to the right is good. And the vast majority of our failures are very small percentage. We do pretty good work most of the time. So those are the major events and accidents and incidents that happen. But most of our events happen in the middle, and occasionally we knock it out of the park and get great results here. I'm making the case as to what safety 2 is. So safety 1 focuses on the red. What's wrong? How do we fix it? How do we prevent it? It's this find and fix methodology, and it's a very small percentage of the things that happen here. So we spend all of our time figuring out, doing root causes, why did this happen, and then putting in place prevention strategies. That's what HRO theory is. That's what everybody's talking about nationally. Nobody has done this in healthcare yet. It's being done in industry, but nobody's done it in healthcare yet. We have a guy at OSU who's an international expert on this safety 2 stuff, and we're working with him to try to figure out how can we do it in our organization. Safety 2 is this other stuff. What goes right? The majority of things go right, but how do we capture why it goes right? How do we capture the workarounds? Workarounds are a bad word, but sometimes those workarounds are how things go right. And so safety 1 is minimize the number of adverse events, react and respond and fix, find and fix, figure out how to prevent, preoccupation with failure. So we're not going to stop being preoccupied with failure. But safety 2 is figure out, maximize the number of normal events, the stuff to the right. Be proactive about why these processes work. Preoccupation with success. Both different messages, maybe two sides of the same coin. Safety 2 doesn't replace safety 1. They're both essential, but nobody in healthcare has figured out how to do safety 2. So if you guys decide to take this on and you figure it out, teach us, because we're just getting started with this. I don't think anybody's working on it right now. So the places to start are the places that have high reliability processes already. This is our adverse drug event chart. I'm not really intended for you to see, but what you see here is that our adverse drug events have gone down dramatically. In fact, it's almost 5 sigma. We have 3 errors per 10 to the minus 5,000 dispensed doses. Highly reliable. We have 4 to 6 medication errors quarter. Pretty uncommon event. So something is going right there, and we don't know exactly what it is. We think they're following policy, and that's, but there may be more to it. So we're going to study medication errors and try to figure out what's going right, and then figure out how to spread that. It's a very reliable process. So most of the errors that we do have are related to the 5 rights, you know, in terms of medication delivery. We're going to find 2 units and study them. Interview frontline staff. We have a long survey questionnaire we're going to do. What happens when you're interrupted? What are some issues you have to do workarounds during the day? And figure out why is this working so well? And then do some direct observations in the unit, focus on the human factors that allow these folks to react to variation, and then spread. So we're maybe 3 or 4 months into this. If I ever come back here again, I'll tell you what we find, or when I see you all come to our course, we'll talk a little bit more about it. But to me, this is the cutting edge next thing that we need to be working on. Diagnostic errors. So we had a 14-year-old sustain a significant trauma from a bicycle accident, concussion cuts, spleen injury, fractures. Taken to our level 1 trauma center, had a long operation, got a lot of fluid in the operating room. In the ICU for 3 days. We gave him some hypotonic fluid. I think it was D5 quarter. Probably should have done half, but anyway, that's what he was getting. Then he started drinking a lot because he was thirsty, and he was drinking, you know, non-salt containing juices. Day 3, started vomiting, headache, nausea. Everybody got all excited about there's something going on in the abdomen. He had all these injuries. We forgot about electrolytes. On day 4, we did some electrolytes. Probably should have done them on day 2. Sodium was 120. So we missed the ball. We had tunnel vision. It was the abdomen. It was the abdomen. It was a surgical problem. It was not the electrolytes. He had water intoxication. We fixed that, and he did fine. But we shouldn't have missed that. You know, that's a diagnostic error that when you look, when I show in these slides like this, how could Nationwide Children's miss that? Well, we did. And I suspect you've had a few of those in your organization as well. We've had 6 recent cases involving delay or inaccurate diagnoses, and I think that's just the tip of the iceberg. I think it's 100 or more. We just don't detect it. We don't hear about it. In January, we looked at our 21 cause analyses, listed diagnostic error as a factor, and tunnel vision was one of the biggest ones. Kid comes in, he's wheezing, he's got asthma. And they forget that it could be a foreign body. And it's asthma. Finally, after they get the chest x-ray, and then you call Rahul to come take the foreign body out. So diagnostic error is in the national scope. 1 in 20 adult ambulatory encounters involve diagnostic error. That's a gigantic number. No numbers for pediatrics that I'm aware of. The Institute of Medicine has got this big, thick book, which I have on my desk but haven't read. But the bottom line is receiving national attention. The New York Times in March said we should do more autopsies to identify diagnostic errors. I think we capture, I'm making this up, 10% at most of the diagnostic errors that happen in our hospital because we're not looking for them. We don't actually know how to detect them yet. So diagnostic error is failure to accurately and timely diagnose the problem and communicate it to the families. That's the Institute of Medicine definition. So, you know, I think a big piece that we're finding is failure to use differential diagnosis. So I'm going to look back there and say the art of differential diagnosis is dying. Why is it dying? I don't really know, but part of it is we're so busy that there isn't time to go through a good differential diagnosis on rounds. You know, you got 2 hours and then you got to get to clinic or whatever. And so we often don't do a good differential diagnosis on many of these kinds of things. So the art of that, I think, is being lost to our younger folks. I grew up on differential diagnosis. These guys taught me differential diagnosis. It's the only way to start the conversation around a problem. But time is an issue and it's a reality. First, focus on the most life-threatening possibilities. Keep the list in front of you until the diagnosis is confirmed. But as I said, it sometimes takes too long on rounds. So in Edward's case, there's actually 88 things in the diagnosis, in the differential diagnosis of nausea and vomiting. So you probably don't go through all 88 things in the ICU, but electrolytes probably should have been on that list when the nausea and vomiting started, and it probably should have, as a life-threatening problem, should have come up sooner. So we're focusing on our organization on detecting these diagnostic errors and figuring out how to bring back the art of differential diagnosis in the context of 2016 healthcare. I put together a senior team. They are working on a diagnostic error index. It's not ready for prime time yet, but figuring out how do we detect it and how do we quantify them, how many diagnostic errors, and having diagnostic timeouts, and then what are we going to do? There's lots of programs online. Brian could tell me about all of them that you can call up on your phone that gives you the differential diagnosis of everything. You know, maybe that's something that we want to do, maybe not. We haven't decided yet. So leaders navigate the forks and the rocks. Leaders support the team. Leaders are a relentless drumbeat on what it is you're trying to accomplish. If you're not paying attention, your team isn't paying attention. If you're not paying attention, your team isn't paying attention. The occasional email from Kurt or the occasional email from me to a team member, a team that's working on stuff, what's the latest on this kind of thing? Creates a flurry of activity if maybe they haven't been working on it. So that occasional email that just says, give me an update, really gets people refocused if maybe they've gotten focused on other parts of their big jobs that they have. But you have to make driving change just how we do business. It's not extra work, it's the work. It's the work. And again, our colleagues from Children's National, we really enjoy working with you, and hopefully you're having a good time coming to our place. We share the vision of achieving best outcomes and harm elimination in our hospitals and around the country. And with that, I got 10 minutes left for questions. 4 minutes. Thank you.
Rich.
Or I could talk for 3 more hours.
Thank you so much, Rich. You all can hear it. This is on. Rich, you're so gracious to come down. I know you're in the middle of a real Joint Commission survey. We have a mock survey, which is nothing, so I really appreciate that. We would have understood if you weren't able to make it. Are there questions or comments? Why don't I just pass this around? Mark Batshaw. Behind you.
Thank you so much. That was really terrific.
Thank you.
You just briefly touched on the issue of how new technology might be able to help. You know, of course, there's Watson as an artificial intelligence program from Microsoft that is being used in some hospitals for differential diagnosis to assist there. With Cerner, there's the opportunity of having bubbles appear to remind you how to do that. Where do you see this technology leading us as an adjunct to all the things that you've spoken of?
Yeah, that's a great question. EPIC has a differential diagnosis tab as well. You know, we're ambivalent about that. Obviously, it's complete, and so there's value in having a reference that's complete. But does it teach people to think about differential diagnosis? So there's probably a role for it, and we're trying to explore that. But I want people to be able to generate the first 6 or 7 things that kill kids from hyponatremia, or the first 6 or 7 things that you need to know that cause hypoglycemia, or hypotension, or hypoxemia, those kinds of things. And I don't necessarily want them always to go to the cell phone and read it, because what you see there is you see a list, but it may not be prioritized. The way I think about diagnosis error is there's 20 things on the differential of status asthmaticus or of wheezing. There's only 4 that kill you if you miss them. And I ask this all the time, asthma, pneumonia, foreign body, and congestive heart failure. And the residents never get the congestive heart failure, which is the 4th thing if you start treating for asthma and it's congestive heart failure. All the other things, alpha-1 antitrypsin deficiency and cystic fibrosis, they're not likely to kill you in the next couple of hours. So what I would like, and maybe I just am not familiar with all of it, the EPIC tool does not prioritize it. It just gives you a list, often organized by organ system. What I want people to be beginning to rethink about is what are the things that are going to cause serious harm in the next 24 hours if I don't make the diagnosis, and then I can figure out the rest of the things. So I think we need both of those. You need the long list, but the list needs to be organized in such a way, especially if you don't have time to go through all 20 things that cause wheezing or 88 things that cause nausea and vomiting. There's really only a few on the nausea and vomiting list that are going to hurt you in the next 24 hours if you miss it. So great question. I don't think we've figured it out, but we are going to use the electronic media in some way.
Thank you very much. That was a great talk. I would like to stay a little on the same subject because I believe you touched a little upon it. I think that the problem is that the electronic medical records do not allow for differential diagnosis. They want only diagnosis. We are missing not only from the trainees, we are missing, I think, even from the consultants, that I cannot write down my differential diagnosis and my priorities, as you said, and how I'm going to go about, because everything is a click, click, click. And I believe you as leaders of hospitals have the power to force the private companies who create the electronic medical records to make them compatible with real medicine and not only for coding and billing purposes. I think this is one of the major challenges that we all face.
So thank you for the compliment that I have the ability to influence EPIC, because I don't. Brian might, but there is a way to codify those things in EPIC. I don't know about Cerner. So it actually can be done in EPIC and maybe can be done in Cerner. I grew up on paper. I understand paper. I like paper. I'm quicker on paper. But it's the electronic world, and we have to figure out how to do it, and I understand it slows us all down. But there is a way to do that in EPIC.
Actually, Brian had the forethought of working with a company called Isabel Healthcare, and we actually have Isabel embedded in our electronic medical record and work with the residents and the medical students. It's actually embedded in the differential diagnosis section, which encourages them to pull out the key features of the case and to encourage a strong diagnostic reasoning process.
Thank you for that. We had heard about Isabel. I don't know if it integrates with EPIC, but I think it does. But thank you for that point. I'd forgotten that.
Kurt, we'd love your
Brian, Rahul, is somebody in the back?
Well, thank you.
Can you say a few words about handoffs and how they impact patient safety and delivery of effective safe care?
So handoffs.
Asking me, Howard?
So a great question, and I'm going to give you an answer that maybe you'll be surprised by. So I think handoffs are essential, and we need to do them, and we need to do them well. But there's actually only one paper that I'm aware of that's shown that good handoffs change outcomes. So what we have with handoffs, the 50 papers on handoffs, satisfaction with handoffs, making sure people have the data from one service to another or from one individual to another. So how can I argue against handoffs? I'm not. But I'm saying what I want people to do is prove in the medical literature, or not even prove, just publish something that says that doing all this work around handoffs actually changes clinical outcomes. There's only one paper in pediatrics around that. I think it came out of Boston. So I think it's the right thing. I think it's important. So that's what I'm supposed to say. But I haven't seen people yet show in the medical literature with a rigorous peer-reviewed study that it changes outcomes. And I'm all about outcomes. I'm not about process. You have to do processes to get outcomes. But if a process doesn't change outcomes, then I'm a little less enthused about it. I think it probably does, but nobody's really been able to show that. So that probably wasn't the answer you were expecting from a QI guy, but I tell you what I think, not necessarily what people want to hear. Yes, sir. Does that answer your question?
Well, perhaps our tools are not adequate to answer the question. That's my big concern.
Could be. Could be. He said maybe our tools aren't adequate to answer the question. He might be right. Okay.
I just want to say thank you for being here. I know Dr. Newman is going to say something as well, but this has been really informative and instructional and just reinforces all of the things that we know that we need to do. I love the concept about safety too and focusing on the successes. Sometimes we don't always do that as well as we should. And so I think this next generation of where we all need to go in the country around pediatric safety is critical. And you're leading the way. And as always, we're great collaborators and great followers of your work. So thank you.
Thank you so much.
Well, Rich, I just want to echo Kathy. I want to refer back, and I completely agree with you, the concern about the lack of critical thinking as we take care of sick patients. I was also struck by your slides, and it's geared to the numbers of patients and numbers of days, but it probably doesn't reflect the increased intensity of the types of patients you're caring for that are counted as inpatients. And so the results that you're showing, it's probably underestimates the impact that you and your programs have had. And the leadership of nationwide, it's great to see national and nationwide there together. I love that, and the leadership of the Ohio hospitals to create a collaborative that now we're a part of, and solutions for patient safety. It's really changing the landscape, and has been recognized by CMS and others as being the model for quality improvement. Thank you for that. Finally, I'd like to go back to your comments about leadership and teams and having a doctor and a nurse lead the team. I want to thank Dr. Holbrook, who's here in the audience, for giving Kathy and I the chance to lead and build our quality and safety team. I can't even remember how many years ago, probably at least 10 years ago. And and now here we are. Here we are, and I love the symbolism for our hospital that we have a doctor and nurse leading our hospital, and thank the board for having that foresight. So thank you for the partnership, and we look forward to continuing to work with you and build on this work. Thank you.
Thank you for your kind words. It's been an honor to come. Appreciate the time.